So please feel free to stop and ask questions or interject at any point. This is going to be just very basic overview of depression screening and management. So here's an outline going over epidemiology and then giving a definition of depression according to DSM-5, and then discussing the development and course, screening, suicide risk assessment, and then treatment. So depression, it's, as I'm sure you all know, very common. The lifetime risk in the US, it's about 20.6%. A statistic that I found very surprising is that almost 80% of antidepressant medications are prescribed by primary care physicians. And also 60% of people being treated for depression are being cared for by primary care physicians in the US. And another statistic that I thought was really outstanding was that about 50% of adults who complete suicide have had some contact with a primary care physician within a month before death. And that was according to a 2017 study. And 80% had such contact in the year right before the suicide attempt. So the current predictions by WHO are that by 2030, depression, it'll be the leading cause of disease burden globally. And at this point, it might be good to ask, so what is depression? So some people may say, oh, it's probably just suicidal thoughts and feeling sad, but really it's so much more complex than that. It can be marked by feeling hopeless, a lot of self-loathing, a lot of, critical negative thoughts, isolating, feeling anxious, feeling guilty, or feeling shame, or even just disconnected from themselves or the world. So according to DSM-5, at least one of the symptoms, it is depressed mood or loss of interest or pleasure. And the symptoms are present nearly every day for most of the day for at least 2 weeks. So I think the 2 weeks, that's key for diagnosing. And then plus 4 more of the following symptoms. So their sleep may be affected. There may be psychomotor retardation or just like a slowness in the body, or even maybe like feeling more restless. Changes in appetite usually decrease, but there can also be increased appetite, and then weight changes, loss of energy, feeling worthless or having a lot of guilt, difficulty focusing, difficulty making decisions, and then suicidal thoughts. And there are 3 main specifiers to think about. So there can be mild. So usually someone who meets the specifier, they probably don't necessarily need medication. Their coping skills are strong, or they're skillful enough that they're able to continue their daily life and meet all their responsibilities without any problems. And then moderate means that there probably is some impairment in their overall functioning, and they could possibly benefit from an antidepressant medication. And for severe, so usually these individuals, their functioning is very much impaired. They may be having very severe suicidal thoughts, and they're at very high risk. Medication usually is recommended. And for some cases, it's so severe that they may have psychotic features and might even need to be hospitalized. So there are different types of depression. The depressive disorder, so this encompasses the major depressive disorder, which is also known as unipolar depression. There's persistent depressive disorder, which is also known as dysthymia, and premenstrual dysphoric disorder. And then there's bipolar disorder, which is also known as manic depression. There are 2 different types. So there's type 1, there's type 2, and then there's cyclothymia, which is a more mild or like a less severe version of bipolar disorder. So at the very bottom, it says pro tip. So always screen for any history of mania or hypomania when you're screening for depression, because it's really going to make a difference when you are coming up with a treatment plan. So brief overview of the diagnoses that I just mentioned. So persistent depressive disorder, this is characterized by low mood and then at least 2 other symptoms of depression at least half of the time for 2 years. So again, when we are diagnosing, we are always looking at the length of time that the symptoms are present. So if you're looking at someone who, they don't quite meet the criteria for major depressive disorder, but they do have some depressive symptoms, but it's been for 2 years, then you would, think about this diagnosis. For premenstrual dysphoric disorder, so usually the symptoms are present in the week right before menses, and then when their period comes, then the symptoms usually will subside. For bipolar disorder, so this is characterized by at least 1 lifetime manic episode, and bipolar 2 disorder, so there is at least 1 lifetime hypomanic episode and 1 major depressive episode. And then cyclothymia, as I said, it's hypomanic or depressive episodes, which happen like more frequently within a 2-year period. So some differential diagnoses to think about, there are a lot. So in addition to everything that I just mentioned, also thinking about substance-induced mood disorder, medication-induced depressive disorder, possible medical conditions that could be the main cause for the depressive symptoms. So the one that I think about is like Huntington's disease. So usually the depressive symptoms, they come on quite early in the course of the illness and even before any major motor impairment. So it's considered like the first neuropsychiatric symptom, or following like a stroke. So major depressive disorder, it's really prevalent for like left frontal strokes compared to right frontal lesions. Other differential diagnoses to think about, so there's schizoaffective disorder, if they have a depressive type, so there may be some psychotic features involved as well. Also ADHD, so that's one that may be somewhat surprising. So sometimes if someone is having a lot of difficulty focusing and difficulty organizing themselves, that can bring on these feelings of depression. And then persistent complex bereavement disorder. So that one is one that we think about if someone's had like a loss and they're still grieving, and it can present like a depression, but it's its own category. And then there could just be sadness, which is a very normal human emotion that sometimes we may overdiagnose or misdiagnose as a depressive disorder. And then some common psychiatric comorbidities. So individuals with depression, they may have history of some substance use. They may have an anxiety disorder, such as panic disorders, OCD. There may be an eating disorder component, so whether they're restricting or they're purging. There could be personality disorders, such as borderline personality disorder. There could be a history of trauma, so perhaps the emotional dysregulation is just related to them being in this hyper-aroused state, like being hypervigilant, very prone to flashbacks, having nightmares, and then, as I said, ADHD. So the development course, there are a few factors to think about. So biological factors, it is estimated that 40 to 50% of the risk for depression is genetic. So that's pretty significant. There are some genome-wide studies that are going on that they're trying to really pinpoint, like what are some gene variants that might be linked to depression. There are some studies that look at brain imaging, and they can see that there are different changes in blood flow for people who are depressed, disruption in neurotransmitter function, and then perhaps physical illness such as like viral infections, or if there's a disturbance in endocrine like cortisol, and then as I said earlier, like Huntington's or Parkinson's disease, diabetes, stroke. And some common medical comorbidities. So individuals with depression, they tend to have a lot more functional impairment, a lot more complications, higher mortality. And because of all of this, they're at much higher risk of cancer, diabetes, stroke, like every medical condition out there. They tend to have poor quality of life and difficulty complying with treatment, and may also be living unhealthy lifestyles. So whether that's smoking or not exercising, or poor sleep hygiene, or not eating right. So some scales that we can use, there's the Hamilton Depression Rating Scale. So that one, it's 21 items. It takes about 15 to 20 minutes to complete and score. And I know as doctors, like time is precious. So usually one that might be easier to try out is the Patient Health Questionnaire. And you can actually use this on the MD Calc app. So it's like very quick to just take out and ask and screen. It takes about like 1 to 5 minutes. So based on the score, you can get an idea, okay, how severe is the depression? And it's always very wise to screen for suicide risk. So there is this suicide risk screening tool that was, it came out of the NIMH study. So there are 4 questions that they'll ask, which is, in the past 5 weeks, or sorry, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? And in the past week, have you been having thoughts about killing yourself? And then have you ever tried to kill yourself? So it's always really important to ask about any history of suicidal behavior in the past. So whether that's like pill overdose, cutting, burning, jumping, going to the subway with thought of jumping in front of a train. So it's okay to ask in detail to make sure you're getting all of this information. So according to this study, they said that if anyone responded yes to one of these 4 questions, there was a 97% chance of someone between ages 10 and 21 at risk for suicide. So these are some really important questions to ask.
There's a question in the chat, I think about the couple of prior slides. Emily's asking if those comorbidities that were listed, are they a higher risk of those comorbidities, the patients that have depression, or those comorbidities are the causes of the depression?
Yeah, so it's a really great question, and I would say it's both. And this is, brings us back to the whole mind-body connection, and how, if our bodies are not doing well, then our mind is probably not doing well. So I would say for the purpose of this presentation, I was mostly looking at medical like comorbidities if there is an underlying depression. And so please feel free to ask more questions. So lab workup that we might do. So these are the generic labs that we will order to rule out any sort of medical etiology for mood disorder. We also want to know, so lipids and A1C, because that might affect whether we want to go with like different kinds of medication that could be affecting, your sugar levels or your metabolic functioning. Thyroid, of course, looking at endocrine, wanting to screen for pregnancy, and then any sort of viral infection, any nutritional deficiencies, and then any possible substances that could be affecting mood. And then if someone is on lithium, Depakote, or clozapine, then you might want to order the medication level. And then anyone who's over 40, we would order an EKG. So this brings us to what medication options do we have? So we have SSRIs. So this includes Celexa, Luvox, Paxil, Prozac, Zoloft. So medications are not without side effects. The more common ones that we encounter are GI side effects. So nausea, vomiting, diarrhea, bloating, sexual dysfunction, weight gain, tiredness, anxiety. For our older patients, we definitely want to monitor sodium level because SSRIs can possibly affect the sodium and cause hyponatremia. And then another category of antidepressant medications are the SNRIs. So this is affecting serotonin and norepinephrine. So this includes Effexor, Pristiq, Cymbalta. The side effects are somewhat similar to SSRIs, but because they're acting on norepinephrine, it can also cause sweating. It can cause, some people say they have like a heart palpitations, heart racing sensation, or feeling very anxious, and then also possible appetite loss. So we'll want to monitor blood pressure, heart rate, cardiovascular functioning, and then we'll also want to monitor their hepatic function. So for example, Effexor, it is metabolized by the liver. So there could be some issue with like elevated liver enzymes if someone already has like a liver issue. And the reason why I put watch out for withdrawal right next to Effexor is because the half-life of Effexor, it's really short. It's 5 hours plus or minus 2 hours. So if someone forgets Effexor, you know, their dose of Effexor by even a day, they may have withdrawal symptoms. So that can look like just feeling really irritable, feeling nauseous or dizzy, vomiting, or even having these uncomfortable, like tingling sensations. So if, you know, Effexor is a medication that you were to think about prescribing a patient, I would always mention, you know, this is a possibility and that it's really important that they, you know, are compliant, they're taking the medication every day. So the NDRI, so this is working on norepinephrine and dopamine. So this includes Wellbutrin. So there is like a sustained release formula and there's the extended formula. So some common side effects you might encounter, headache, weight loss, insomnia is one that's very common. Again, because it's working on norepinephrine, so it's kind of like more activating, and then possible constipation or fast heartbeat. So some contraindications for Wellbutrin, any history of an eating disorder, because Wellbutrin can cause appetite loss, weight loss, and then any history of a seizure disorder, because it does lower the seizure threshold. So you want to be extremely careful. And then similarly to the to like SNRIs, monitor hepatic function. So I actually had a patient who this was with his he had a history of getting hospitalized for he had like really like high liver enzymes and like this transaminitis, and the only thing that they could like deduce was that he recently got started on Wellbutrin because he had no history of any GI issues prior to that. So they actually like had to taper him off of the Wellbutrin. So really important to think about that. So this is a noradrenergic and specific serotonergic antidepressant, which is called Remeron. By the way, I am using the brand names, but I included the generic names as well. So some common side effects for Remeron are drowsiness. Some people may feel lightheaded, maybe eating more, and because of that, they may gain weight. So you always want to monitor weight for someone who's on Remeron. And then similarly to the SSRIs, you want to check sodium level for anyone who's like a high-risk patient, like over 65 or using thiazides or other hyponatremia-inducing agents. So our tricyclic agents, that includes Elavil, anafranil, Selanor, tofranil, and Pamelor. So because these medications, they're working on like our alpha adrenergic, histaminic, and they're blocking the muscarinic as well. So this common side effects can be like hypotension, sedation, dry mouth, constipation, urinary retention, blurry vision, confusion, and also would be important to monitor sodium. So how to choose the right antidepressant. I really recommend this book, Successful Psychopharmacology by Dr. Sobel. It's a really light read, easy to read. I think it's really to the point with just, telling you how to, what is your thought pattern and what kind of algorithm can you follow in choosing a medication. So the first thing that Dr. Sobel says is to use side effects to your advantage. So if you have someone who is having insomnia and they are also depressed, you might want to choose a medication that's more sedating. So that might be Paxil, Luvox, or Remeron. On the flip side, if you have a patient who is just like feeling very lethargic, they feel really heavy, they can't get out of bed, then perhaps you use a medication that's more stimulating. So Prozac, Fiberid, Wellbutrin, or an SNRI, so like Effexor could be a good option. If you have a patient who hasn't been eating, they've lost a lot of weight, then maybe you choose a medication that would increase appetite like Paxil or Remeron. And then contrarily, like you could also avoid side effects. So if you have a patient who's really afraid of gaining weight, which is something we all hear a lot, maybe you choose Prozac, maybe you choose Wellbutrin because those are known to be less likely to cause weight gain. If you have a patient who has a lot of stomach issue, maybe they have reflux, perhaps you go with Remeron or Paxil. If you have a patient who has any sort of heart condition, then like you would want to avoid Celexa, which could potentially increase the QTC. And then if someone has a history of hypertension or arrhythmia, you'd want to avoid the SNRIs. If they are concerned about sexual side effects, which is I hear a lot from my young male patients, then perhaps you would want to choose Wellbutrin. That tends to be less likely to cause sexual side effects compared to SSRIs. And then going back to the discontinuation symptoms that I mentioned earlier, so that would include Effexor and Paxil Prestige. So because of the shorter half-lives, this category probably would not be good for someone who is not the most compliant or is forgetful with taking medication. The medication that's least likely to cause the discontinuation symptoms, so that would be Prozac because it has a much longer half-life, and we'll talk more about the half-lives of medications later. And then again, the medications that are at greatest risk of hepatotoxicity, so that would be bupropion, and then some other ones to think about, like I just included here. So amitriptyline, trazodone, duloxetine. And also thinking about comorbidities. So if this patient has like an anxiety disorder, they might actually need higher doses of the serotonin antidepressants. Again, if they have an eating disorder, avoid Wellbutrin. If the person has bipolar disorder, but they're having a depressive episode, you might choose Wellbutrin, and then avoid any serotonergic or any of the antidepressants other than Wellbutrin, because the serotonergic transmission can increase risk of a manic episode. And then I think the rest you can read, but I don't want to repeat myself. But perhaps the one that we haven't talked about is if they have chronic pain. So the medications that might be helpful are Cymbalta, Effexor, and Prozac, because these medications can actually decrease the experience of pain because of their function on the pathways in the spinal cord. If you have a patient who is like geriatric, they may actually be more sensitive to the anticholinergic side effects. So you would want to avoid Paxil. Also avoid the more sedating medications because they're more vulnerable. So that could include Paxil, Remeron, Luvox. And then also they're more likely to be on a lot of medication. So also to be mindful of drug-drug interactions. So medications that are less likely to like inhibit P450 and have drug-drug interactions would be Lexapro, Lexa, Vibrid, Effexor, Prozac, Remeron. And then for pregnancy, some good options are Prozac, Zoloft. Avoid Paxil because this is a category D. There's possible higher incidence of major cardiac defects. And then if someone is breastfeeding, then good options are Zoloft and Paxil. They're known to have lower undetectable levels in breast milk. So if there's anything that you take away from today, choose these three. They're less likely to have side effects than the others. So these are usually a safe bet. So medication management, I know that you may have heard 4 to 6 weeks is about the amount of time that the medications will start to work in medical school, but truly you can start to see improvement if it's the right medication within the first 2 weeks. And then a rule of thumb is that if there is not at least a 30% better improvement in symptoms by week 4, then you could consider increasing the dose. And then I'm sure sometimes, patients will be like, okay, so does this mean I have to be on the medication forever? Like, when can I stop the medication, if ever? So according to Dr. Sobel, so that book that I recommended, so he's saying that you would treat for like 9 to 12 months. And then if the patient wants to discontinue, then you could try that. But if they relapse and they have a second episode of depression, then they'll probably have to go back on the medication, and then you should treat for another 1 to 2 years. But if they want to stop and then you come off of it, and they're 70% more likely to have another third depressive episode. So at that point, we would probably recommend maintenance treatment. So they would just stay on their antidepressant, just like they would stay on their metformin. So trying to help the patient understand that, oh, it just seems like you're doing well on this medication, and this is what is keeping your mood stable. So how do you stop or switch an antidepressant? So a direct switch is when you go from one medication and then the next day you start a new one and you stop the previous medication. So that method I would really only consider if the antidepressant, they have similar short half-lives. So an example would be Zoloft, or Zoloft, the half-life is about 26 hours, and then Lexapro, it's very similar, like 27 to 30 hours. So for those medications, you could potentially go from Lexapro and then the next day switch to Zoloft. For moderate switch, so say you have medication A, you would taper off of it, and then there would be this washout period, perhaps like a few days before you start medication B. And this is to try to decrease the risk of drug-drug interactions. More commonly practiced is a gradual taper or a cross taper. So that means that you're tapering off of medication A, and then as you're tapering, you're also starting medication B. But I mean, the risk really is that there could be potential drug-drug interactions. And then I put in quotes here something called a Prozac bridge. So because Prozac, the half-life, it's so much longer compared to the other medications, it's like 4 to 6 days. Prozac can be used as a medication to help with any discontinuation syndromes as you're tapering a medication. So let's see. So again, what are discontinuation symptoms one might experience? So for an SSRI, that could be feeling really dizzy, feeling nauseous, headaches. Some people complain of these brain zaps where they just feel almost like their skull is being electrocuted, and then like feeling really irritable, having difficulty sleeping. So because of these symptoms, we might give Prozac 10 or 20 milligrams to try to ease those symptoms as they're coming off of whatever medication they're on. So really important takeaway as well, never co-administer any of the medications just discussed with a MAOI. So more specifically, Nardole-Parnate, Marplan. And then also don't administer within the last 14 days of having taken like any of the medications we went over. So it is with Prozac, again, because the half-life is so long, wait even longer. So don't administer within 5 weeks of like the patient having taken Prozac. And the reason being, so Serotonin Syndrome, it is a life-threatening emergency. It is characterized by altered mental status, autonomic instability, hyperreflexia, hyperthermia. So more than like 20 years ago, there was the death of an 18-year-old patient, Libby Zion, in New York City. And that was the result of co-administration of meperidine and phenelzine. In that case, like it's still thought of today just because it was related to this drug-drug interaction that ended fatally, unfortunately. So some other drug-drug interactions aside from the antidepressant medications, so general anesthetics, if given with the MAOI, could result in like prolonged hypotensive effects, and then even like a decongestant, so like phenylephrine, could result in like a hypertensive crisis. So whenever, if you see an MAOI, be very, very cautious. And getting near the end here, I thought I would just comment on physician mental health. So, to be a doctor, you have to be somewhat self-sacrificing, like probably a little neurotic, probably somewhat masochistic. So these numbers, I hope it's not scary, but just realistic. So the physician suicide rate, it's estimated at twice the risk of the general population. And with one completed suicide every day, so US doctors have the highest suicide rate of any profession. And then medical training suicide, it's relatively rare, but it remains the #1 cause of death in male residents and the #2 cause of death for female residents. So I'm just leaving here some resources, just so that we all know that we have help. We can always reach out. Even more resources, if not for yourself, you could probably share with your patients. There are different hotlines. Even, some of these organizations even have support groups that your patients could attend. They're like drop-in. They don't even have to contribute. They could just attend. They could have their camera off. So just to help people feel like more plugged in. And then also for LGBTQ, different mental health resources as well. So thank you all for your attention. And if there are any questions, I'm happy to answer.